Yeah. Thank you, Kamaljeet sir, for those kind words, and thank you, Professor Shrikant and Professor Kamaljeet sir, for giving me this opportunity. So I'll be talking about prophylactic lasers in retina more from a point of view of comprehensive, ophthalmologists, from general ophthalmologists, like what they should practice. So as we all know that the incidence of retinal detachment is in 1 in 10,000, and rheumatogenic retinal detachment are the most common type of retinal detachment. So the risk factors being axial myopia, cataract surgery, probably where there is vitreous loss, vitreous prolapse, and surgery in younger patients, ocular trauma, a contralateral rheumatogenic retinal detachment, and certain peripheral degeneration, especially the lattice degeneration. So what does literature has to add? What does literature says about the prophylaxis? So one of the recent studies published in Retinites says about idiopathic GRTs, the incidence is decreased from 43% to 13 odd percent if you do a prophylactic laser 360 barrage in the fellow eye, and the macula on RD, the incidence reduces from 70 to 1.3 odd percent. So the relevant areas where the vitreous is particularly adherent is the vitreous base, the retinal vessels, certain degenerations like lattice degeneration, and these point of adhesions are most likely to cause retinal breaks during the pathological event, that is posterior vitreous detachment. So what is safe? What are asymptomatic breaks? These are the breaks like operculated and atrophic round holes. There is no vitreoretinal traction at the edge of these breaks. And in asymptomatic horseshoe-shaped retinal tears also, they just carry a risk of 5% to cause retinal detachment. So sometimes we do encounter asymptomatic detachments also. So the asymptomatic detachment, actually, the risk of progression to clinical detachment is 11 to 31%. And an equivalent percent of the asymptomatic detachment cases instead achieve spontaneous resolution before a clinical detachment occurs. So the idea is you could closely observe, or initially you can do a prophylactic treatment. For me, it would be a prophylactic treatment if there is a asymptomatic retinal detachment. So there are the ones which need treatment are the symptomatic breaks. These breaks are characterized by the perception of increased flashes and floaters, and they usually occur due to increased vitreoretinal traction during an acute episode of posterior vitreous detachment. Posterior vitreous detachment itself carries 10 to 20% risk overall of causing an acute break. The two important prognostic signs are pigmented cell or hemorrhage in the vitreous at the time of initial evaluation. And if there is a hemorrhage, there is an approximate 70% of these patients will have at least one retinal tear, and nearly one third of these patients will have multiple breaks, and almost 90% of these tears are located superficially. So the denser the vitreous hemorrhage, the higher the likelihood of a retinal tear is present. And in the absence of vitreous pigmented cell or vitreous hemorrhage, the risk of retinal tear during a PVD is just 2 to 4%. And there is also a 2 to 5% risk of patients developing retinal break in the subsequent week. Symptomatic breaks are the ones which have a persistent vitreous traction at their edge and which denotes all tears, retinal dialysis, but it rarely includes operculated holes. They yield retinal detachment in 50% of the time, and when you do a later laser retinopexy, the risk is reduced to less than 5%. So this is important here. Now coming to one of the most specific peripheral degeneration, that is lattice degeneration, and this needs a special mention here because this is one which has a firm vitreous adhesion, and traction on these lesions typically produce retinal tears at the posterior lateral edges. So lattice degeneration is seen in 6 to 8% of the general population, and 30% of the rheumatogenic retinal detachment occur in these eyes. Inversely, the lifetime risk of a retinal detachment in a patient with lattice is less than 1%. So lattice degeneration, it causes RD by two ways. Either there is a PVD or there isn't a PVD. So where there isn't a PVD, it's a progressive atrophy, and with PVD, so we'll come to this in the next slide. So progressive atrophy without PVD, it's the retinal hole may develop in as many as 35% of these lesions and tend to occur in young myopic. Localized retinal detachment, it occurs in 2% of the cases, and if they do become clinical, they expand relatively slowly. Though treatment is only warranted in cases of expanding retinal detachment, regular follow-up of all patients with such atrophic holes is critical. When it is with PVD, then these are the cases where you have to treat, because these are the patients where there is a traction is present. Or so what about the contralateral eye with lattice and with other eye has an RD? So lattice is present 45% bilaterally, it is present in 45% of the patients, and the risk of detachment is present in the contralateral eye is 5%, which is as high as 25% in myopics, with prophylactic therapy reducing the risk by threefold. So to sum up, in lattice degeneration, indications for treatment of lattice is with tractional holes or break within it, symptomatic glasses where there is a flashes and floaters, RD in other eye, patient undergoing refractive procedures, and lattice with subclinical RD, even if pigmented and appears old, one-eyed patient, family history of RD, and atypical lattice degeneration. So there are certain lattices where you can observe when it is asymptomatic, when there are no breaks or holes with atrophic holes, when it is pigmented, but still there are no breaks or holes. So we have two modes of delivery. It's slit lamp and LIO to generate regions of confirmed chorioretinal adhesion. The idea is to counter vitreoretinal traction and prevent liquefied vitreous from passing into the subretinal space to generate a retinal detachment. So laser coagulation, photocoagulation, what we do is we make a 3 near confluent rows of laser. Among the strongest and therefore the most pathologic regions of vitreoretinal traction occur at the vitreous base, and far peripheral regions like they necessitate treatment to ora serrata, as the most common reason for treatment failure is insufficient laser placed around the anterior margin of these breaks. So laser photocoagulation, we have to titrate to yield moderately wide burns. Then there are certain conditions like media opacity, shallow retinal fluid, or relative paucity of RP and choroidal melanocytes, where you may necessitate use of higher power. And laser retinopexy is generally performed with a duration of 0.1 to 0.2 seconds, with shorter duration treatment requiring more powers. So longer exposure may be more effective in cases with media opacity or shallow SRF, and spot size also affects photocoagulation. Smaller spot size with yield a higher power per unit area than a larger spot size. Therefore, caution should be used to avoid rupture of Brooks membrane. So with LIO, it is preferred for retinal tears which are there in the periphery. A disadvantage of this delivery system is the variability in the laser spot size, burn intensity, delivery location, all inherent qualities of delivery system where the laser lens target are independently mobile and unfixed. And spot size also increases as the power of hand and lens increases and more hyperopic the patient is. And scleral depression also decreases the spot size by bringing the target tissue closer to the laser source and focusing the lens. So I'll skip this. Now slit lamp, it is there for patients with mid-peripheral tears in whom positioning at the slit lamp is preferred. High power contact plus contact lens can provide a view of area necessitating treatment, while also offering stabilization of the patient's eye. This provides a real inverted images, and these lenses often modify the laser spot size, and therefore actual area of photocoagulation of the retina is increased. So for tears, further anteriorly, some physicians preferred mirrored negative power concave lens. Such negative power lenses create virtual erect images, and patient cooperation can further assist visualization of the retina with the patient looking away from a given mirror, providing a more anterior view. I'll just sum up. So the complications are inadvertent laser to the macula, choroidal effusion, epiretinal membrane, hemorrhage of the retina, vitreous and choroid, choroidal neovascular membrane, and formation of new retinal breaks. Follow-up is important, and where you find the treatment is inadequate, you always have to go for retreatment. And my take-home message is that it is easy to learn and do more. It is important that indication should not be missed, and people doing medical retina, they do lasers at time. And in case of any doubt, do not hesitate to seek an advice from your vitreoretinal friend. Thank you for your patience listening. Thank you.